Hello, good morning to all of you. I'm Dr. Pramod Sharma uh, from the Professor Department of Pharmacology, and today I will be taking a topic or discussing a topic which is of quite clinical relevance because it is a major public health problem worldwide. This is, as I belong to a Department of Pharmacology, I will be discussing drugs that are specific to migraine treatment. Why I have chosen this topic? Because worldwide, if you see, as per the current estimate, almost 1 out of every 7 individual is suffering from this disorder, and this disorder is so disabling that it affects the patient's quality of life, can disrupt its normal lifestyle and all that. And this disease is characterized by recurrent episodes of headache, often that is unilateral, throbbing in nature, pulsatile, and may vary in intensity from mild, moderate, and severe. And not only that, it is associated with certain other features like nausea in many percentage of cases, vomiting even, phonophobia, photophobia, and this has more predilection towards female, and it has a strong genetic disposition as well. So this was a small, introduction to the class or this migraine. Exactly, this falls under medicine. I am not supposed to discuss a lot about the medicine part of the disorder, like signs, symptoms, and all that, how it presents, and but this was important to get make you familiar with the disease itself. So unless until we know the pathophysiology of the disease, we cannot know where exactly in the pathophysiology pathway a drug should act. So we need to identify target. Based on that, we have certain drugs which act on different targets and ultimately leads to abortion of such an attack if that is acute in nature, or we can use it as them as prophylactic therapy, which will ensure that no future headache occurs during the lifetime of the patient. That is the ultimate goal, though that may not be achievable in many cases. But we have tried a lot of medications, and very important thing is that the selection of this topic is also is based on the fact not only it is a major important public health problem, but there is a lot of advancement, new drugs and all that have been approved in recent past in this particular disorder, for this particular disorder. And this is a disorder of serotonin, which is a neurotransmitter. This is a abnormality in that pathway, serotonin pathway, serotonergic pathway, and that leads to this migraine. So if we go by the treatment or drugs available for migraine, there are many. And very important thing is that this serotonin, which is the culprit here, is acting on variety of receptors. It has almost 7 type of receptors, and more important here in migraine pathophysiology or for the treatment are the 5-HT1 and 5-HT2 receptor. Though 5-HT1 has the major role to play, other than that there are other neuromodulators, genic peptides, and other inflammatory mediators. They do play a role, and we have tried to block them as well to achieve a therapeutic goal. We all have heard a group of drug very commonly known as triptans, because they are the drug which are considered as migraine specific drugs. And these triptans, there are many like fluvatriptan, sumatriptan, elatriptan, naratriptan, jolmitriptan, and all that. Sumatriptan came first, and it is available through in almost all form, and can be given through subcutaneous routes, rectal, nasal spray, everything. So what these triptans actually do, they have a unique mechanism of action. They target the receptor, as I discussed, that serotonin has a variety of receptor 5-HT1 to 5-HT7, 7 sort of receptors, and there are subtypes as well. So it actually targets the 5-HT1 subtype 1B and D. So these receptors are present on the cranial vasculature and trigeminal nerve, because the facial sensory supply is through trigeminal nerve, that is the fifth cranial nerve, and this headache is because of the extracerebral blood vessel dilatation. And what happens because of this dilatation, the certain appendages around dura, they get stretched, and dura is also stretched, and dura is pain sensitive, so that causes pain and all. So these are extracerebral vasodilatation. It is actually a defect in the cerebrovascular vasculature that gets abnormally dilated, and that leads to type of symptoms which we have discussed already about migraine. Not only that, after this cranial vasculature dilatation and all that, the serotonin can lead to release of certain peptides like calcitonin gene related neurokinin A substance P, that further leads to vasodilatation causing edema, further stretching of the dura, accentuating pain and all that, neurogenic inflammation and pain, sensitization of certain sensory nerves to pain mechanism and all that, because serotonin can also sensitize pain fibers as well as these peptides as well. So these drugs, triptans, as I said, they are 5-HT1B, 1D agonists. Remember, these are agonists, not antagonists. As serotonin is degraded by monoamine oxidase enzyme, that is why whenever we are using triptans in any particular individual, we should avoid combination with MAO inhibitors, because there is a risk of exaggeration of action of serotonin, because that will not be degraded and can result in a condition like serotonin syndrome. Though there are certain triptans like frovatriptan, elatriptan, naratriptan, they are less likely to cause, or there is minimal risk associated with those triptans. They should not be used in combination with ergotamine, which is also a drug used in acute attack, because there is at least theoretical risk of increased chances of coronary vasospasm, so that might result in some sort of problems to the patient. So it should be avoided within 24 hours. They should not be co-administered at least, or they should be spaced by at least 24 hours after giving ergotamine. There is also a risk of serotonin syndrome with combined use of selective serotonin reuptake inhibitors, serotonin noradrenaline reuptake inhibitors, because they also facilitate serotonergic transmission, so that also can lead to serotonin syndromes. The good thing is about triptans is, as early as you use them, they are more effective, and if they are combined with NSAIDs, that is non-steroidal anti-inflammatory drug, which is usually the first medication or first class of drugs to be used in migraine attack, but they are not migraine specific, because NSAIDs are used in variety of conditions. So we cannot name NSAID as specific, migraine specific. So there are FDCs available like sumatriptan and naproxen, that is available. Other than that, we have other NSAIDs that I will be discussing in later slides. But triptans are not devoid of risk. They should be used with caution, or they should not be used in patient those who are pregnant, those who have uncontrolled hypertension, those who have basilar migraine, hemiplegic migraine, or those who have IHD or ischemic stroke, etc. These kind of patients should not be given triptans for abortion of acute migraine attack. I was talking that there is much work is going in this area, and as a result, we in the recent past several new drugs or group have been approved for the use in this specific condition called migraine. So these groups have been named as GPANTs, DITANs, and also monoclonal antibodies. GPANT is a group of drugs which actually are antagonists of the receptors of calcitonin gene related peptide. As I said, when the serotonin activate these receptors, 5-HT1 receptor, the release of these peptides, and these all peptides can lead to neurogenic inflammation, further edema, increased vasodilatation and all that, pain, sensitization, etc. So these are receptor antagonists, so thereby we can prevent the action of CGRP, and that may lead to abortion of a pain attack. And these drugs, GPANs, are also meant for treatment of acute attack of migraine. So some of the examples are Rimegepant, Abrogepants, and Zavegepant. The Zavegepant is the newest addition to this, and this is probably has been approved by US FDA, but yet to come to the market, hit the market very soon. Lamiciditan is fall under a category called detans. This is one of the only agent is still only available. There could be many in future will come definitely, but this differ from Japans that triptans, that it has high affinity for 5-HT1F receptors, and it is an agonist actually for this receptor, and the mechanism of action is almost similar to 5-HT1B and D. So lasmiditan is also one of the addition in the armamentarium of the drugs which are meant to abort an attack of migraine. We have, this is the era of the biological agents. So this migraine is also is one of the conditions where we are trying all our effort to develop such agents for treatment of acute attack and all that. So we have calcium G related peptide monoclonal antibodies. These monoclonal antibodies actually bind to CGRP and do not allow this molecule to bind with its receptor. Here monoclonal antibodies binding to the molecule itself. These are not receptor antagonists. So it is not able to bind to its receptor. So we have certain agents, many agents, in fact, erinumab, galcanjumab, firmanjumab, aptinzumab. The advantages with these drugs are that they are to be given at a longer interval, monthly interval, or some of them can be given every 3 months. But the only the problem with these agents are they are very costly. So in a country like India, I think they will be of little use because very few can afford it. But considering the disabling nature of this disease and how it interferes with the patient's lifestyle, disrupts his routine life, maybe people can go for these kind of agents as well. If you talk about other drugs, as I said, NSAIDs are not migraine specific drug. So we have several NSAIDs. We can use aspirin, we can use naproxen, we can use ibuprofen, we can use ketorolac, we can use acetaminophen. There's many, and as I said, they are available as FDC, fixed dose combination with sumatriptan, like naproxen is present with sumatriptan. So these drugs are to be tried in patients who have mild attack. These are the drug of first choice actually. And in case of a little difficult to treat pain, people have recommended use of opioids like oxycodone, morphine, etc. But they are not as effective as migraine specific drug. Rather, they runs the risk of developing tolerance, dependence, abuse, and they are more associated with the medication overuse headache. So we should not try opioids. Opioids are usually, if you look at the current scenario or current status, opioids are hardly employed in the treatment of, but in rare instances they could be of some use. Metoclopramide, as I said, this migraine is associated with nausea, vomiting and all that. So metoclopramide is an anti-emetic drug which can be given IV as a monotherapy in case of acute attack of migraine. Not only that, parenteral, prochlorperazine, chlorpromazine, these are antipsychotic drugs. They can also be used because they all block dopamine receptors, so there is high risk of having acute dystonic reaction. So we should be prepared with that, and we can use prophylactic promethazine or dimenhydrinate, etc. to prevent such events. So metoclopramide can be used in acute attack as a monotherapy, but not oral metoclopramide. But whenever you use metoclopramide with other drugs orally, the advantage of metoclopramide is that it has it has a prokinetic effect. So it promotes the promotes the gastric emptying as well as enhances the tone of the lower esophageal sphincter. So that way it is good. It serves some benefits. So whenever you use it orally with other drugs, so it serves some purpose, and it is available in combination with many of these anti-migrainous drugs. Ergot alkaloids, we have ergotamine, which is also available as sublingual, oral, rectal. The same mechanism of action as with the triptans, they also have agonistic activity at 5-HT1B and D receptors. But the problem with ergotamine, they have partial agonistic activity also on alpha receptors, so they can cause serious problems, vasospasm and all that. And that is why ergotamine should be, should not be used within 24 hours of the triptans, or there should be a gap of 24 hours because of increased chances of vasoconstriction in the coronary vessels. Not only that, these drug is to be given 2 milligram during an attack. If attack is not subside, is not responding, you can repeat similar 1 to 2 milligram every 30 minutes, but you should not give more than 6 milligram in a day. That is the the upper limit of ergotamine. And the hydrogenated product of ergotamine is the dihydroergotamine, which is a less potent vasoconstrictor than the ergotamine, but it is a potent vasoconstrictor. This also binds with the same receptor. But IV dihydroergotamine is very effective in acute attack of migraine, but the efficacy of ergotamine is very doubtful. As we know that whenever there is acute attack, we have a variety of drugs available which can take care of the to abort an acute attack. Patient can get relief of that disabling headache. But there are certain population of patients who repeatedly have this headache episodes quite often. So such patients are actually the ideal candidate for migraine prophylaxis drug. We have drugs which can prevent or can be used as maintenance therapy that can prevent attack of migraine in future. So such drugs are not to be used in every individual. There are candidates which are actually ideal to be given this prophylactic therapy, such as the patient who are having more than 2 attacks in a month, or a person who is requiring more than 2 times the abortive treatment to treat acute attack, or patient who have contraindication to the acute treatment, or is acute treatment is not effective, or patient is having kind of acute attack that is lasting for 24 hours or more, or disrupting his new routine life, or maybe causing great disruption is quality of life of that patient. So such patients are actually candidate for migraine prophylaxis. And not only that, the patient who are routinely using treatment for acute attack, they develop a condition called migraine medication overuse headache. So that is another entity which is another problem. When we do not take right treatment for the migraine, the person who is in need of prophylactic therapy but he is relying on only abortive therapy, such patient develops MOH, and that is why it is recommended that the use of sub medication should not be more than 3 days in a week or more than 10 days in a month. Otherwise, the separate entity may develop, the patient will develop headache in absence of drug. That is called medication overuse headache. So there are a variety of drugs that are fit for migraine prophylaxis. If you use them, patient is likely not to have repeated attack and his quality of life is improved. So among them, the first group is beta blockers. We have metoprolol, propranolol, and timolol. They have established efficacies, but atenolol, nadolol are also may be effective. That has been claimed. But the problem with these beta blockers is they are slow in onset and they take time, because you need dose titration, and after reaching to a target dose, you have to maintain that dose for at least 3 months to declare a particular beta blocker not to be effective in migraine prophylaxis. So you need to wait for at least titration and that 3 months maintenance period. And this should be avoided in patients over 60 years of age and those in smokers. Other than that, we have another group that is calcium channel blockers. There we have verapamil and flunarizine. Verapamil is a voltage gated L-type calcium channel blocker, which is considered as a first line drug, but its efficacy is not that good. But flunarizine is a non-specific calcium channel blocker. It has better efficacy, though it is considered second line, but it has better efficacy than verapamil. Antidepressant like tricyclic antidepressant, amitriptyline, nortriptyline, etc. They have proven efficacy in in migraine prophylaxis, but the data, sufficient data, is not available for or justifying use of SNRIs like venlafaxine or duloxetine. Among anticonvulsants, these drugs also, other than anticonvulsant effect, they do have a role to play in migraine prophylaxis like topiramate and sodium valproate. and we have a compound called divalproate sodium, which is an equimolar concentration of sodium valproate, as well as the free valproic acid. These are the drugs which are approved for treatment of migraine prophylaxis. And in case of refractory migraine which is not responding to at least three of the abortive treatment, despite giving adequate dose for in adequate doses, then these patients may require some other therapy which is used off label nowadays, that is called Botox or botulinum toxin A. It is for intractable and chronic migraine. This is to be given as an injection in in temple or scalp, and that can reduce intensity and frequency of the pain for after 2 to 3 months, and this injection is to be repeated every 2 to 3 months, and that can afford symptomatic relief to the patient and can reduce the number and, as I said, the intensity of the pain in such patients. Methisazide, you will be surprised to know this methisazide 5-HT2 antagonist as such if you see, but this is a second line drug used in migraine prophylaxis and rarely used now. But how does then it help? Because blocking 5-HT2 will promote vasodilatation, and the main pathophysiology in the migraine is vasodilatation of extracerebral vessels. But this methisazide also have partial agonistic activity at 5-HT2 receptor. That is the reason why methisazide was sometimes a treatment for migraine prophylaxis. So I think I have discussed in short the two class of drugs which are available for migraine specific drugs. One that takes care those which take care of the acute attack, and one for maintenance therapy to prevent future attacks or further attacks to make patients quality of life much better. And NSAIDs, I said, they are not migraine specific because they are used in every condition of related with pain and all that. So, but they are the drugs which are used in as a first line drug for any migraine pain. If it is not controlled with that, then we switch to migraine specific drug. And other than that, associated symptoms like vomiting, nausea and all that, we can use metoclopramide and other antipsychotic drugs which I have already discussed. So I think this serves your purpose in a short and crisp form. I have delivered this, and this should help you understand the migraine pathophysiology and its overall treatment. This is all from my end. Thank you very much. Thank you.